Quinn and Howard, thank you for putting this together. San Diego Shoulder Institute, wonderful place, and all the other speakers here. Thanks. I'm excited to share some of our thinking on this. I don't have any conflicts. Um, we in Kaiser Permanente, we get the need to move to the ASC. You know, we're in a prepaid system. It's all cost centers. So if we get people to not spend as many nights in beds, heads in beds, it saves the beds for more acute patients. And frankly, in a prepaid system, it sort of saves money so that money can be placed into other people. So this study we did at some point in the past, we proved that same-day discharge was not inferior to in-house for 90-day readmissions, 90-day ED visits, and one-year mortality. And the patients had more satisfaction. And as Dr. Clifto said earlier, patients really kind of like it when you kind of give them these new protocols and regimens because they really enjoy the extra attention in many ways. So why do we need better pain control? We need to get pain control right. This was a great study by Matt Saltzman, who was a fellow with Dr. Mattson and team in Washington that kind of showed pain pumps really, we hurt people. So we've whiffed on this before. So we need to get pain control right. And if pain control isn't done well, we've in our own study shown that pain and falls are top reasons for early return to care after primary elective shoulder arthroplasty. So for just those two and many other reasons, we have to get it right. So we kind of started a long time ago with the idea as pain was the fifth vital sign, and the Institute of Medicine put that out there, and there was a lot of extra pain meds that were placed and given to people, and we were probably contributing to the opioid epidemic. I think all of us know patients that we think, wow, did I make that guy an addict or not? So then there was this idea to walk away from opioids themselves, and so newer thoughts emerged on pain control and the idea of multimodal strategies, and other external factors kind of made us think more about how to manage pain in all settings, especially the outpatient settings. And so in California, there was something that came about in many states the same, that where you have to check in and let people know kind of what kind of pain meds you're giving as well. The COVID-19 pandemic made outpatient cases mandatory, and there was no more parenteral, so we had to rethink how we did pain control. So interscaling nerve blocks, a lot of this you all know. We did our own study to look at this as a major benefit, and we were able to kind of decrease the time in the hospital space, just in the recovery room itself. But then we were able to see that it could help, and others did great work on this. This is the NYU group. David Ding's now a orthopedist in the Kaiser system, but when he was a resident, I think he did this study, and they saw that with interscaling nerve block or regional anesthesia, they had lower in-hospital complications and readmission rates, and decreased odds of a hospital readmission as compared to general anesthesia. And our friends, Dr. Clifto and Anna Quenze and others in their system looked at both liposomal bupivacaine and non-liposomal, and they both had great benefit, and there was no difference in ED visits or readmits. But all these studies are kind of looking at the idea of interscaling blocks and how they're so beneficial. I did mention multimodal pain control earlier, and Dr. Namdari, who's one of our speakers today, his group looked at this at Rothman, and they described a multimodal approach, and they called it TLC, tender loving care. And that approach, as compared with the idea of a pain pump, a traditional kind of idea of a patient controlled anesthetic pain pump. The TLC method with multimodal had better scores in pain control. They did use a little bit more narcotic and a millimeter morphine equivalents in the first 24 hours, but the patients were much more satisfied, and that's part of the deal. We want patient satisfaction. satisfaction and to get keep our patients happy and under pain control. Ortho Carolina, which has done a lot of work on this, especially Nadi Hamid and his team, they looked at the idea of outpatient shoulder arthroplasty with multimodal, and they saw that they had successful outpatient shoulder arthroplasty with multimodal and no interscaling nerve block. They had less 90-day complications, similar ED and UC visits as compared with other regimens, and so that was really kind of a great finding and kind of led us forward. That same study did really outline one of the first multimodal frameworks. If some of the others of you have presented before that, I'm sorry if I dissed you. But you see in this medication period, pre-op, intra-op, and post-op, as well as home, they did have Percocet and gabapentin. It's interesting that later on they've kind of come into thinking about opioid reduction and almost no opioids. So we did look at the idea for risk factors after post-operative opioid use, and we saw that 1 year post-op use was high before we performed a systematic reduction. And then we had a later paper that showed that once we did a systematic reduction, both we switched our electronic medical record to have a standardized approach to the prescriptions and really a much lower amount of opioid, as well as the state monitoring that I described earlier, and surgeon advocacy. That was like mainly people who were kind of suits, and also orthopedic surgeons who had to tell people how to do things and kind of monitor them. And in our system, we do unblinded, tracked, and trended use, and people see how much they're giving, and then they kind of are somewhat shamed into kind of getting along with the program. And so we were able to show that we had improvement in use of opioids and a decrease and reduction. So this is the narcotic-free regimen that I was telling you about, and that same Ortho Carolina group and others had looked at this, and they looked at a multimodal opioid free pain management pathway. It was safe and effective, superior pain relief versus traditional opioid-containing pathways at 12 hours, 24 hours, and 2 weeks post-operatively. Really great study. And you see in their regimen, in the post-op and discharge periods, there's no narcotics. So it's really exciting, and some of the others of us are trying this. I think it's a long way to go to describe this to a patient and make them think that after a total shoulder, they're not going to get any narcotics, but it's been done, and I hope more of us go in this direction. This is a recent literature on ASC shoulder arthroplasty and pain control, and in it there's interesting. A lot of the regimens look similar, and I'm just showing you these papers so that you can read on for yourself. But this was our Detroit friends that put this together, and I will tell you that in our own system, we're looking at changes in opioid prescription by race and ethnicity after shoulder arthroplasty, and we're looking at overdose risk with the combinations of opioids and gabapentinoids. Those two papers will be out soon, and they're going to help further describe kind of some of these nuanced issues with opioids and non-opioids in post-op pain control. What about perioperative behavioral modification? This is Ragnar Lothbrok, or at least the actor who played him. And you know what the Dutch surgeons say when patients say, "Am I going to have pain?" They say, "Surgery hurts." They just tell the patients, like, the surgery hurts. But this is really far from pain as the fifth vital sign in the Institute of Medicine back in the day that I showed to you earlier. But I think the general approach here is we have to gird our patients to prep them for what is to come. We can't tell them that it's not going to hurt at all, and because I think that was the pain as the fifth vital sign approach. Keep patients out of pain completely, and that's probably not the right approach. There are apps like Curable, Kaya Health, and Happify that institute a bit of cognitive behavioral therapy to keep people like ready for pain and understand. Relieve RX is another one, and even things like mindfulness and yoga to help prep patients for the the postoperative regimen and how they will feel things and what they will respond to and when it's appropriate to take on narcotics and how a little pain is actually appropriate. I just say to people, if you like had a brother and they punched you, you're probably going to do better with your total shoulder than if you've never felt pain in your life. If you've lived that life, I don't know, it's going to be a little bit harder. Um, and so in our system, we've talked about value-based care, and we've looked at things like the volumes of patients and where they are. And we have a lot of shoulder patients that come in with their complaints, and we do a lot of shoulder operations. This shows kind of the volumes of the patients. And so we've built out systems that kind of focus on perioperative virtual monitoring, asynchronous texts and hot links that talk through the pain issues in the postoperative period. And these patient touch points and pain control reminders are really helpful for our patients. And then we allow patients to connect with patient care coordination nurses. And in this way, we get patients away from the ED to the clinic if they're having pain issues so that we can better monitor them. I'd rather talk to the patient myself or my PA talk to the patient in the postoperative period than an unknowing, guessing emergency medicine physician who's not dealing with this as much. And so I think that's the way we can manage through this. There's other options like vitamin C. It presents complex regional pain syndrome, and just a little vitamin C every day in the post-op days, you can really decrease the amount of pain that the patient's feeling. So it's interesting that Chris brought it up in the peri-op nutritional benefit period. In the post-op period, it helps too. The future is now. Cold therapy is old, but cryoneurolysis and things like that are new. Some of this you've heard before. TENS unit, peripheral nerve stimulation, cannabinoids, the byproducts of weed can help. Creams have this in it. Duloxetine or Cymbalta with its serotonin norepinephrine inhibition of reuptake can help reduce opioid requirements post-op. So there's lots of combos. In us, how are we doing? We're doing over 85% of our patients are going home the same day, up to 90% by the end of 2025. I don't have that data point, but you see midway through the year, it was we were doing about 86%. And we also have balancing measures to see if they're staying home. We chose return rate, so returns to urgent care, returns to the ED, and readmissions. And not all of them, like Dr. Clifto said, are associated with the surgery, but some of them are. So we monitor ourselves in this way to have a balancing measure to see if sending a person home the same day is reflected in good care and they're happy there, or if they're bouncing back. So this is our balancing measure. So in conclusion, pain control is key to the Surgery Center shoulder arthroplasty success. Physical therapy and motion are important. I didn't mention those. I didn't mention creams per se, which are also helpful. Interscaling nerve block, multimodal, opioid reduction, and pain-free regimens are emerging. Behavioral modification helps. Systems innovations guide good pain control. Vitamin C is cheap and easy. There are other new ideas emerging. I think you have to monitor your interventions. Good luck, and thank you all for this time with you tonight.